Good morning to one and all. I would like to thank the organizers for giving me this opportunity to present two papers in the seventh year in review breast cancer. So I'm Dr. Sanjay M H, radiation oncologist from Sayadri Hospitals, Pune. To begin with, the first paper which I'm going to present is basically presented at the ISMO Congress. It was the first report of the Hypo G01 phase 3 trial, which looked into the acute toxicity of a 3-week versus 5-week regimen for local regional breast cancer radiotherapy. Now, if you look at the background, everyone knows breast radiotherapy has evolved from conventional fractionation to start A and start B hypofractionation schedules. And the local controls were well studied and analyzed, and hypofractionation is considered safe and effective. So, in this study, Hypo-G phase 3 trial, acute toxicity of 3-week versus 5-week regimen was compared and analyzed. Now, if you look at the study design, basically it was a non-inferior phase 3 trial with the intention to treat analysis of over 1,264 patients from almost 29 centers. And if you look at the study design, basically there were women more than 18 years, T1 to T3, N0, N3, M0, and cancer with the indication of regional nodal radiation. They were basically divided into arm A and arm B. And arm A was a similar to STAR B protocol where the 40 grain 15 fractionation regimen and boost was investigator's choice. And arm B also has conventional fractionation of 50 grain 25 fractions with the investigator's choice of boost or no boost. And the primary objective was basically lymphedema. That was the arm edema. Now, if you look at the results, these were the treatment characteristics, very nicely poised, very nicely balanced about the mastectomy, axillary clearance, radiation techniques, IMRT and 3D, tumor bed boost, and the systemic therapy options were all well balanced in the treatment characteristics. And if you look at the adverse reactions from maximum grade per adverse event from base to 1 month after radiation, if you look at both the charts, pruritus, dyspigmentation, breast nipple edema, pain, dermatitis are almost similar in both the groups, and limited adverse events greater than more than 2 and no grade 4 or grade 5 reactions were observed. Now look at the acute dermatitis, which was again categorized based on the BMI, that is body mass index, less than 25, 25 to 30 and more than 30. Now if you look at this chart, more than grade 2 dermatitis were frequent in patients with a BMI of more than 30. And in both the arms, in fact, and it was not significant in both the arms. So there was no difference in the acute dermatitis in comparing in both the hypofractionation arm and the conventional arm. So in conclusion, women receiving local regional RT acute toxicities with a 3-week moderate hypofractionation are mild and raise no safety concerns. Further long-term follow-up is ongoing with a primary analysis planned next year. And together with an ongoing DBCG Hypo 2, basically SCAGAN trial 1 is a prospective meta-analysis. That results are awaited. That will tell us how these acute toxicities can be analyzed and whether it is safe or not safe to use, because the longer follow-up is still needed. So hypofractionation radiotherapy has gained popularity over the last 10 years. 10 years back, the long-term data came from the Lancet, which was published in 2013, showed no difference in local control and toxicity profiles in standard and hypofractionation arm, respectively. So in START B, breast shrinkage, telangiectasia, and breast edema were significantly less common normal tissue effects in the 40G group than in the 50G group. So take-home message I have for this paper is basically hypofractionation is currently the standard of care as well as for early as well as locally advanced breast cancer. START trials have demonstrated the same after the 10-year follow-up of study. And Unicancer Hypo-G study has also shown that 3-week hypofractionation regimen is safe, though a longer follow-up is required to establish the same to have any meaningful recurrences or significance about this study. So coming to the second paper, this was published in JAMA. Basically, it was about effect of elective internal mammary nodal radiation on DFS with women in node-positive breast cancers. Now, if you look at the background, radiation of the internal mammary nodes is an individualized approach. Now, I would use it in my clinic where it is very, very essential. Not all patients do get this treatment. And among patients who are pathologically node negative axillary, up to 10% may harbor regional metastasis to internal mammary nodes. The risk of metastasis increases almost 40% if axillary node positive breast cancers comes. That's why IMN radiation is thoroughly studied. But the logic behind it is quite controversial and it's quite uncommon. No one uses it quite common in our clinic. So this study was designed to assess the impact of elective IMN in the node positive patients. Now, this design was a multi-center phase 3 randomized clinical trial, which was conducted from 2008 to 2020 at 13 hospitals in South Korea. And women with pathologically confirmed node positive breast cancers, breast conservation surgery or mastectomy with axillary lymph node dissection were eligible. And all patients underwent regional nodal radiation with breast or chest wall radiation. And they were randomized to 1:1 to receive radiotherapy either with internal mammary nodal radiation or without internal mammary nodal radiation. The primary endpoint were 7-year DFS and secondary endpoints included the rates of OS and the breast cancer specific survival and toxic effects. Now, if you look at the results, good follow-up of almost 100 months. The 7-year DFS did not significantly differ between the two groups with internal mammary nodal radiation and no internal mammary nodal radiation with a log rank p value of 0.2 and hazard ratio of 0.80. However, an ad hoc analysis, basically they did a subgroup analysis of patients who were medial and central quadrant tumors. So if you look at that subgroup, that showed higher DFS rates with IMNI among patients with mediocentrally located tumors. Now in this subgroup, the 7-year DFS were 81.6 without internal mammary nodal radiation versus 91.8 with IMNI with a p-value of 0.008. And the 7-year breast cancer mortality rates were 10.2 without IMNI and 4.9 with IMNI with a p-value of 0.04. No differences were found between two groups in the incidence of adverse effects, including cardiac toxic effects or radiation pneumonitis. Now look at this Kaplan-Meier curves where nothing is significant. Look at the DFS, breast cancer mortality, disease metastasis-free survival, overall survival, all statistically insignificant, though there was some benefit with the use of internal mammary nodal radiation. And this is a forest plot where you can see again a non-significant data, where at the end you can see none of them, overall, there was no significance in the hazard ratio. Hazard ratio is more than 1 in this case. So the possibility of rise in DFS was shown in this study, not statistically significant. This was possibly because of a lower than anticipated event rate with a corresponding loss of statistical power in the study. The findings suggest that including internal mammary nodal radiation in regional nodal radiation would be beneficial for patients with mediocentrally located tumors. And moving on to the discussion, basically the effectiveness of IMN radiation is controversial, particularly in medial to located tumors or positive axillary nodes because of chance of microscopic disease is quite high. Now, why we hesitate in clinic to give internal mammary radiation is basically of 3 things. Number 1, the recurrence rates are quite low, that is less than 1%. Number 2, if you look at the cardiac and lung toxicity are quite high in the techniques which we use. And also the availability of such good systemic agents, which negates the routine use of internal mammary nodal radiation. So the absolute 7-year DFS benefit of 3.4 with internal mammary nodal irradiation was similar to the results of regional nodal irradiation, which was published in MA20 trial, EORTC 2292 or NCIC CTG trial, and many French randomized controlled clinical trials. The present study was designed to detect a difference of 10 points, basically 70% versus 60% in the 7-year DFS. This assumption was based on a Korean retrospective study that found 10-year DFS of 65 with IMNI and 57 without IMNI. This was overestimated for several reasons. And this study also showed among a subgroup of patients with medially centrally located tumors, 42% of the study population, DFS was improved by 10% in the IMNI group. The breast cancer mortality and disease specific survival are also significant in IMNI in this small subgroup analysis. Therefore, we believe that benefit of internal mammary nodal irradiation was affected by the tumor location, and that patients with mediocentrally located tumors can be considered to receive IMNI when performing regional nodal irradiation. But this subgroup analysis was not pre-planned. Hence, when you interpret these results, they should be interpreted with a lot of caution because this was not a planned analysis. This happened because of the subgroup analysis in the study. So the take-home message I have for internal mammary nodal radiation is internal mammary radiation should not be routinely considered in node-positive patients. At present, there is no randomized evidence that has shown convincing benefit of IMN radiation. Though few studies have shown benefit in medial and centrally located tumors, but it's only in subset analysis and not a well-designed randomized controlled trials. So in future, a well-planned analysis is warranted, which will look into medially and centrally located tumors to eliminate this bias of tumor location and the benefit of internal mammary nodal radiation. Thank you.